Hello, everybody. Today we'll be talking about the antibiotic prophylaxis for dental procedures. Now, this PowerPoint is based on the updated therapeutic guidelines. And while we're looking into this, I'll also be talking about the new changes because I know that some of you guys who are attending for not for the first time, it's really hard to forget and relearn something which you've been used to something, but I'll try to clarify to the best possible extent. All right, now let's look into the overview of antibiotic indications. And now all these references are from therapeutic guidelines, and there is nothing which I added from other sources because I understand that it's really important for you to follow the instructions as per the therapeutic guidelines for your ADC. Now, so basically, when are we using antibiotics? Okay, to keep it simple, we are using antibiotics to treat the existing infections which are odontogenic, or sometimes we are using antibiotics for the necrotizing gingivitis, which is previously called as NUG, to prevent infection at the surgical site. Now, antibiotics are rarely indicated in this case, but we need to use antibiotics, especially to prevent the infection uh, around the area uh, when you replant an avulsed tooth. Now, this has been specifically mentioned in the new therapeutic guidelines, so you need to pay attention, and possibly there would be an MCQ for this one. And of course, all of you know that to prevent infective endocarditis, so we'll be doing, for that reason, we'll be using antibiotic prophylaxis. Now, there's a lot to unpack, especially when you have to, when we're discussing about antibiotic prophylaxis. For that, I'm aiming to create another PowerPoint presentation so that I can talk about it much in detail. Now, let's look into the endocarditis prophylaxis. Now, when are we doing it? Now, as per the new therapeutic guidelines, the endocarditis prophylaxis is only recommended when a patient meets two criteria. Okay, now always keep in mind, if you suspect there is a requirement of prophylaxis, you need to know that it should tick off two things. One is the procedure which you're going to perform, is it going to be a high risk procedure? And this, that's ticked off. And then the second one could be, does the patient have a high risk cardiac condition? So when you tick both these things in your head, then only the patient is a suitable candidate for antibiotic prophylaxis. I hope this is clear information. Now let's look into the procedures which fall under the high risk category. Now, generally, those procedures which involve manipulation of gingival or perioapical tissue or perforation of oral mucosa, like these general extractions, implant placement. Sometimes there's requirement of biopsies, soft tissues, scaling, or at times reimplanting avulsed teeth. So these are the procedures which the therapeutic guidelines specifically mention that they fall under the high risk category. Now there are other procedures which been mentioned, not related to our dental area, but uh, uh, those involving skin or skin related structures or musculoskeletal tissues. Now, as per the respiratory tract or ear, nose, and throat procedures, if a patient is undergoing tonsillectomy, adenoidectomy, or if there's someone's undergoing invasive procedures to treat an established infection, let's say there is an existing abscess which is draining. Okay. Now the next one is genitourinary or gastrointestinal tract procedures. Now this is again, it's been mentioned in therapeutic guidelines, so I'm just mentioning it to you. But I'm assuming most of the time you'll be having scenarios based on the dental procedures. So just look at the top bit of this slide, and these are the areas which are categorized to be falling under the high risk procedure. Now, there is another one which you have to be aware of. We got antibiotic prophylaxis, and then there is another one which is called a surgical antibiotic prophylaxis. Now, not much to say about this because surgical antibiotic prophylaxis is rarely indicated in general dental practice, but it is required for some specific oral and maxillofacial surgical procedures. Now, this is something which has been specified, and you know that you guys will be assessed based on a, a, a graduate dentist level. So I'm not assuming that there will be a question which will be asked about surgical antibiotic prophylaxis. So you can take it easy in this area. Now, there are some things which have been mentioned, like surgical antibiotic prophylaxis. I'll just keep it fast, like complex things like insertion of a prosthetic material other than dental implants. So just remember this. Antibiotic prophylaxis or surgical antibiotic prophylaxis is not required during the placement of dental implants. So they are talking about other prosthetic materials. Open reduction, internal fixation of a mandibular fractures done by a specialist, and intraoral bone grafting procedures done by some specialist, orthognathic surgery done by specialists, cleft lip and palate repairs done by specialist. So just touch basing those details. Now it also talks about surgical prophylaxis, where you have to look into certain things. Benefit, you have to check the risk analysis, which is benefit versus harm. So prophylaxis involving efficacy in reducing infection against risks like diarrhea, hypersensitivity, and bacterial resistance. It's one thing. Then it talks about immunocompromised situations where you need to consult a specialist or have a multidisciplinary approach. Now, again, this is specifically mentioned in case of dry socket. There is no requirement of antibiotics for dry socket, as it is the reason for dry socket is clot lysis, not infection primarily. Now, this is from the table 13.12. So again, it clearly talks about two different areas where prophylaxis, surgical prophylaxis is required and where it does not require surgical prophylaxis. Again, where does it not require? If you look into this, it pretty much falls in the dentist area, general dentist area, I would say, like the third molar surgery, tooth extractions, routine dental implant insertion or removal, periodontal, periapical surgery, soft or hard tissue biopsies. Now, where it doesn't require is, again, the same thing, insertion of a non-dental prosthetic material, where there is open reduction, internal fixation, sorry, where it requires. So all these are extensive procedures, okay? Now, I highlighted this for a specific reason. So prophylaxis is not routinely indicated for implant insertion because it only increases retention by 1 to 2% without reducing infection risk. So if you can look at the benefit of prophylaxis for implants is it only improves the retention by 1 to 2%. So realistically, it's not much. So I think the whole process of dental implant placement in a sterile environment, it's important. So some of the highlighted areas about antibiotics. So if you look at this, antibiotic choice may need to be made according to the patient factors, including the presence of infection, recent antimicrobial use, colonizing with multi-drug resistant bacteria, prolonged hospitalization, or the presence of prosthesis. Now, it's somewhere in the therapeutic guidelines, I also read that antibiotic choice, that's something I'll try to cover in a different, I think in a different PowerPoint, or I'll add later to the slides here about antibiotic choice. It's interesting. Okay. Now, if you look at the overall antibiotics, so cefazolin is the most effective than vancomycin in preventing postoperative infections caused by methicillin susceptible Staphylococcus aureus. So you can say that cefazolin is on the top. Now there is this mentioning of Staphylococcus aureus carriage increases the risk of postoperative infection. Preoperative screening and targeted decolonization may be warranted. Okay. Now, in some areas, it did mention about pulse culture when if before you give, if you want to give a specific antibiotic, you have to send the pus which you obtain for culture sensitivity, and based on that, you can give the suitable antibiotic. In some cases where you don't have so much room for pus culture, like an emergency, then you start the empirical antibiotic uh, drugs, and then later on, once you obtain the culture results, then you can start giving the, or you can change the antibiotic if needed. So that's been mentioned in the therapeutic guidelines again. Now, surgical antibiotic prophylaxis must be administered before surgical incision. Make it a point. So you have to do this before the surgical incision. Now, how long before the surgical incision? So if you're looking into some short-acting antibiotics like cefazolin, it should be administered no more than 60 minutes. That means let's take it an hour before incision. For long-acting antibiotics, you can give uh, them about 120 minutes, which comes to about 2 hours before the incision. Okay, so that's important. So about antibiotic prophylaxis. Now, a single preparative course dose of antibiotic is sufficient for significant majority of procedures. Okay. Now, if you look into small minority of procedures, there is not enough data to show that the single dose of antibiotics is as effective as 24 hours of prophylaxis. For these procedures, post-operative doses can be considered, but prophylaxis should not continue beyond 24 hours. So, in short, um, when there are minor procedures, they say that there is not enough data to show that a single dose of antibiotic prophylaxis is effective as a 24 hours of prophylaxis. So, for that reason, you can also consider post-operative doses, but prophylaxis should not be continued beyond 24 hours. So that taking post the procedure, you can not give prophylaxis dosage for beyond 24 hours. So just remember this point, very important. So again, it's the same thing, which is summarizing. So timing administers 60 minutes prior to incision. And if it's a long acting, 120 duration. A single preoperative dose is sufficient for many procedures. So just keep it simple. A single dose of antibiotic prophylaxis is enough. Now, presence of these bacteria, Staphylococcus aureus, carriage increases risk. So should be screened or targeted decolonization may be required in this case. Now let's look at the rationale of endocarditis prophylaxis. Okay. Now the risk is high, is up to 15% in elderly patients. But again, they say that for dental procedures, it's rare. Okay. Now there is certain restrictions and evidences which are a mixed bag of results. So uh, they're basically not saying anything. So recommendations limit prophylaxis to high-risk patients undergoing high-risk procedures. So you're doing for, we discussed before, where exactly are we giving antibiotic prophylaxis? We should tick off those two areas, remember, we just discussed earlier. Now, most of the guidelines, they come from expert studies. So unrestricted prophylaxis show conflicting results, which basically means that there's not enough data to have a proper evidence. Now, how are we managing a patient for preventive measures? Let's say this falls under the management cluster. So there's a lot of emphasis in the new therapeutic guidelines about maintenance of oral health. So they say that daily activities like brushing and flossing cause more frequent bacteremia than occasional dental procedures. So you can imagine that something which you've been following religiously, now basically what they're saying is you're brushing your teeth every day, you're doing it probably twice a day, and that's actually causing more bacteremia than the dental procedures which are occasionally done. So for that reason, what's required is regular checkups, and daily brushing and flossing are more effective than one-off prophylaxis. Okay. Next one is timely treatment of bacterial infections and avoidance of unnecessary invasive procedures. Now, discouragement of IV drug use and avoidance of tongue piercing or tattoos. So they did talk about uh, piercings and tattoos. Discourage the patients, that's what they said. But they did specifically mention about avoidance of tongue piercings. Now, again, there are two different things here which been mentioned. One is high risk procedures, which are dental extractions, implant placement, gingival or periapical manipulation, subgingival scaling, and replanting of false tooth. Now, there are also mentioned about high risk cardiac conditions. Now, note that these two are different. What are the high risk cardiac conditions? Prosthetic cardiac wall placements, prosthetic material used for wall repair, patient having previous infective endocarditis, someone's having ventricular assist devices, congenital heart disease, cyanotic or repaired with defects, and then the rheumatoid heart disease, history of rheumatoid arthritis. So these two, you see, these two are different categories, but any of these two are ticked off, then you should be giving them prophylaxis. Okay. Now, coming to the dosages, pretty much the same like previous therapeutic guidelines, standard procedure, amoxicillin 2 grams, and for a child 50 milligrams per kg body weight. You can give a maximum up to 2 grams, right? And a patient with non-severe penicillin allergy, you can give cephalexin 2 grams, and child 50 milligrams per kg body weight. Now, patient who has a history of severe penicillin allergy, you have to go with doxycycline, which is 100 milligrams, or azithromycin, 500 milligrams. You see the change there? So there is standard, there is non-severe, history of non-severe penicillin allergy, and there is severe penicillin allergy. Now, the severe penicillin allergy has changed a lot. Previously, clindamycin was used. Now they say that clindamycin is no longer recommended due to severe adverse reaction risks. Now let's look into managing penicillin hypersensitivity. Okay. When we look into the penicillin hypersensitivity, we got non-severe, severe, immediate, severe, delayed. Non-severe, patient comes with rashes or delayed reaction, where cephalexin is generally acceptable. Okay. And then when it comes to severe, immediate, so anaphylaxis, which is severe, airway compromise, hypotension. Now there is a severe delayed response, which is stress and organ involvement. So all these are important. Look into doxycycline. Uh, when you're taking doxycycline, take with water and remain upright. Those are specific instructions given for 30 minutes to avoid esophageal uh, irritation. And then followed by azithromycin, which can apparently it prolongs the QT interval. So if you're planning to give azithromycin, you have to consult the medical practitioner. Oh yeah, I forgot to mention. DRESS means it's called as a drug reaction with eosinophilia and having systemic symptoms. Okay. Now, parenteral regimes for um, antibiotic prophylaxis, infective endocarditis prophylaxis is amoxicillin 2 grams, cefazolin 2 grams, azithromycin 400 milligrams. Now let's look into some questions and discussions. Okay, I've compiled few MCQs for your reference. So what I'll do is I'll just scroll it slowly, but you guys, based on your convenience, while you're going through the questions, you can pause it, think about the answer, and then the next slide is usually the answer. So just have a look into this, and I hope it helps you to reassess yourself. So that's a quiz. So I just put a hint below that. All the best, guys. All right. Thank you very much for your attention. And please like and subscribe to the channel, and which will encourage me to upload more videos and will be helpful for you guys in the long run. Thank you very much. See you next